So Dr. Groot is an associate professor of medicine, associate director of the Diabetes Translational Research Center here at Indiana University. She's a clinical health psychologist. She has research that looks at mechanisms of linked diabetes and depression, as well as the development of interventions that treat depression among adults in socioeconomic and culturally diverse populations of this disease. And she's actually quite prolific as a researcher. She's contributed more than 90 articles and presentations to a lot of the psychosocial aspects of type 1 and type 2 diabetes. So we are really an honor to have her with us. So if you help me welcome, this is Dr. Groot. Thank you.
Okay, I have this one on. Perfect. And it sounds like we're live. Good afternoon, everyone. All right, a little more energy this time. Good afternoon. Wonderful, wonderful. Well, we're so glad that you're here, and I'm delighted to be able to join you this afternoon to talk about mood disorders and chronic disease. Thank you, Dr. Lambert, for the invitation to come and for all of the conference organizers. I think just based on what I heard this afternoon and also what was on the agenda for this morning and tomorrow, I think everyone here should get an honorary medical degree in hepatology at the end of the conference. So you've really got some wonderful information. So I'm here today to talk with you about mood disorders and chronic disease. As Dr. Lambert mentioned, my area of research is diabetes and depression. And so my role here today is to really give you an overview of what we know and what we don't know about mood disorders and AIH. And I'll compare what we know, what is known, to what we know about diabetes. Diabetes and depression both have inflammatory aspects to them. And so this analogy, although it's a very different disease than AIH, does have some common features, both in terms of its chronicity and in terms of inflammatory components. And so it's a starting point, and I hope to inspire you to participate in research as it becomes available in the future for the psychosocial aspects of AIH, so that we can really build on the really limited literature that's out there right now. As a diabetes and depression researcher, I'm frequently giving talks about diabetes and depression. And I had a good colleague from the University of Michigan who was presenting at a talk a couple of years ago, who turned to me and he said, "You're giving a talk on diabetes and depression. Does that mean by the end of the talk I'm going to be depressed?" And so I'm talking with you today about mood disorders and chronic disease, and I hope not to induce a mood disorder. Just talking about it does not induce it, so good news for you. But do hope to share with you what we know and also then some strategies for what you can do if you recognize some of these symptoms, either in yourself or in a family member or in someone else. And so there are resources. There's good news about mood disorders, and we'll be sharing that, so you can stay tuned for that. I'm also very pleased to be joined by Dr. Shelley Johns at the end of this session, who will be talking with you about chronic fatigue and some really wonderful steps that you can take to address those symptoms as well. So I'll start off and give you an overview of the lay of the land, if you will. Okay. So we know that chronic diseases have a particular ebb and flow to them. Every chronic disease is somewhat different. AIH is different than type 1 diabetes or type 2 diabetes, type 1 diabetes being a juvenile onset diabetes, typically, that has an autoimmune etiology. Type 2 diabetes is the more common form, and that typically is associated with insulin resistance that can be associated with being overweight or obesity. But whether it's AIH or diabetes, we know that chronic diseases are long-term disorders, hence the word chronic. They have waxing and waning symptoms and symptom profiles over time. And typically chronic illnesses such as AIH require consistent adherence to multiple medications or other self-care routines, whether that's imaging, multiple doctor's appointments, refilling prescriptions. Many self-care behaviors go hand in hand. We also know that, and we know this well from diabetes, and we suspect that this would be true in other disorders as well, that the impact of disease can be very different when the disease begins in childhood, or whether it begins in young adulthood or adulthood, and that even when a chronic illness begins in childhood, the relationship to that disease changes over time for the patient and for the family. And so chronic is not only something means that the disease stays with you, but also that there's a relationship that's formed with that disease, and that changes over time. We also know that chronic illness plays a role and can significantly change roles that the patient may play in work or family or community life. And so we don't want to minimize the role that chronic illness plays. That will be different from person to person. That will be different from stage to stage, but that can be a presence in a person's life. And we also know that chronic illness not only affects the patient, but also affects the family. And so in diabetes, one of our main messages has been that people may be individually diagnosed with diabetes, but it's the family that experiences diabetes. And so that we have every reason to believe that that would be true in AIH as well. So let me start by talking about mood disorders then. So what are mood disorders? They're a cluster of symptoms that come together for a specific period of time. We have mood disorders that are along a depression spectrum, and I'll say more about what we consider that to be. There's distress that can be disease-specific. And so we have diabetes-specific distress, for example, and I'll talk a little bit about that. And then we have mood disorders that are more anxiety-based, and I'll define what I mean by those as well. So if we're talking about depression, this has been defined. We have a variety of different diagnoses that count as depression. Major depressive disorder is defined by the American Psychiatric Association as a period of at least 2 weeks in which a person feels consistently depressed or down most of the day, nearly every day. So this is different than having a tough day or having a stressful commute home. This is a consistent feeling of feeling sad or blue. That can be accompanied by or replaced by a consistent feeling of lack of interest or pleasure in things that you would ordinarily enjoy. Added to those two core symptoms can be changes in appetite or weight. And again, they're consistently present over at least a 2-week period, and that can be for much longer than 2 weeks. That can be a matter of months or even years. There can be changes in sleep patterns. There can be too little sleep, too much sleep, or interrupted sleep. Fatigue, and Dr. Johns will be talking much more about that in a bit. Decreased ability to concentrate, feelings of worthlessness or excessive guilt beyond what you might ordinarily feel if you weren't feeling depressed, feeling physically slow or alternatively agitated, and for some people when they're feeling depressed, they may have thoughts of death or of self-harm. We can contrast that to what we call disease-related distress. And in diabetes, this is a multifactorial concept where it's primarily defined as feelings of emotional burden in response to a recommended care regimen that can involve interpersonal factors, maybe working with family members, working with others, having your workplace understand your disease, and can also involve relationships with healthcare providers. We know that disease-related distress shares a little bit of overlap with depressive symptoms, about 30% of overlap, but in fact it is different and at a lower level than what we would consider clinical depression. And so it's important to make that distinction. When we're talking about anxiety disorders, the main core concept behind anxiety disorders is feeling keyed up, fearful, anxious, or having repetitive thoughts and worries that interfere with day-to-day functioning. And there's a spectrum of different anxiety disorders to choose from here. Panic disorder is characterized by having panic attacks that are a sudden feeling of anxiety that comes on within 10 minutes, typically out of the blue, unrelated to whatever is going on in that particular moment. Agoraphobia can be the fear of crowds or closed places, being hemmed in, and worry about having a panic attack in the future. Specific phobia can affect treatment for chronic illnesses, such as fear of needles. So having lab tests can be impaired by that fear. Social phobia is typically understood as the fear of speaking, eating, or writing in public. Obsessive-compulsive disorder is characterized by having repetitive thoughts that are unwanted, going over and over again, or involved in checking behaviors, things that the person feels that they must do in order to make sure that everything is okay. And again, these are consistent symptoms over time. And then finally, generalized anxiety disorder is a spectrum of anxious feelings around different domains of life that leave people feeling keyed up and on edge. So what have we learned about mood symptoms in chronic diseases? Well, I'll share with you is the literature that we know about autoimmune hepatitis, and then I'm going to compare that to what we know about type 1 and type 2 diabetes. Something to be aware of is that the numbering for type 1 and type 2 in diabetes is just the opposite as it is in AIH. That is, type 1 diabetes occurs in children, type 2 AIH occurs in children. So I hope this won't confuse you too much. There are very few studies that have been done with patients with AIH, and unfortunately, none of those studies have been published with individuals with AIH type 2, that is childhood AIH. And so we have a real dearth of understanding about how mood symptoms may be affecting pediatric populations. But what we do know from the few studies that have been done with adults, a study by Schramm and colleagues out of Hamburg, Germany, found that 1 in 10 adults rated themselves who had AIH type 1 reported elevated depressive symptoms. So 1 in 10, or about 10%. In a separate study that was done by Socklingham that was based out of Britain, they also measured elevated depressive symptoms. This was a sample of about 52 patients. The study from Hamburg involved a sample of 103 patients. And in that latter study, 1 in 6 adults reported elevated rates of depressive symptoms, so a little bit higher rate. If we compare that to diabetes, what we've learned is that across type 1 and type 2 diabetes, in diabetes, 1 in 4 adults report elevated depressive symptoms, although rates of clinical depression are lower, they're 1 in 8. When we look across pediatric samples in diabetes, so these are children with type 1 diabetes, we see a prevalence of depressive symptoms anywhere from 9 to 26%. So the rates in general in diabetes tend to be a little bit higher than what the few studies that have been done in AIH to date. If we look at disease-related distress, what do we know? So a study that was done at Yale by Srivastava and colleagues found that there were higher rates of overall life event stress in those with active immune activity compared to those who were in remission with type 1 AIH. In the study by Schramm, they reported that 47% of their patients reported concern that their children would develop AIH. In that same study, a third of their sample reported worry about developing liver cirrhosis for themselves, and 38% of patients reported worry about the prospect of liver transplant. And again, in terms of disease-related distress, we don't have any data on what that looks like for pediatric samples. You'll note here, too, that the number of people in these studies is fairly modest. So 103 is a good number for a study, but because we have limited number of studies and a limited number of people, we don't really know how representative these samples are of all people with AIH. And so that's where we begin with this literature, and certainly hope that you can contribute to building on that. Other kinds of distress. So this was the study that was done at Yale by Srivastava and colleagues found additional themes. They asked people to identify, well, what are some of the things that involve stress for you? And so many of us might be able to relate to some of the things on the list that was put together by these 33 patients. So physically demanding activities for those who were involved in combat or wartime stresses, arguments or tension with family members, stressors associated with being a student, close friends becoming ill, mental illness in a family member, difficulty with home, difficulty with life space, literally where people are living, stability in their home life, and difficulty with conception. And so these kinds of stressors, one of the things that I hope that you take away from this list is that there's a wide variety of stressors that people are reporting are impacting their AIH. And these, of course, make sense. If we look at anxiety then, what does anxiety look like for people with AIH? Again, the study by Schramm out of Hamburg found that 1 in 12 adults identified clinically elevated anxiety symptoms, and 1 in 8 adults with type 1 AIH reported similar symptoms in the Socklingham study. If we compare that again to type 1 and type 2 diabetes, among adults with type 1 and type 2 diabetes, it's 1 in 5, so it's a little bit higher rate, and that's also true for children with type 1 and type 2. Some of that is generalized anxiety, and some of that's specific to self-care routines, such as fear of needles, checking blood sugars, and other kinds of self-care behaviors. Okay, so this is all great, right? So we've got all these numbers. Now what do I do with it? Well, we care about these numbers because they do have an impact on health outcomes. And so we're still learning a lot more when it comes to AIH about how mood disorders may play a role. We know from other disorders, and there's some evidence in this literature, that it's a two-way relationship, that mood symptoms can influence medical outcomes, and certainly medical status influences how we feel. It influences our sensory experience of how we physically feel, and it can also affect us in terms of mood. In the Socklingham study, they found that increased mood symptoms were associated with decreased adherence to prednisone and other oral medications. And this is important because we know from many of the speakers earlier today that adherence to the medications can make a big difference in terms of preventing flares and improving the course of the outcome. We also have seen that there's decreased quality of life associated with increased mood symptoms. There can be a relapse of immune symptoms, and across all liver diseases, this was not specific to AIH, but across a spectrum of liver diseases, increased mood symptoms, particularly in the clinical range, can be associated with earlier mortality. If we compare this to diabetes, we see very similar trends. So we know that mood symptoms make it much more difficult to manage self-care in diabetes. They are also associated with worsened diabetes complications, decreased adherence, decreased quality of life, increased functional disability, and increased early mortality. So just as we care deeply about mood symptoms in diabetes, we have some early evidence in AIH to suggest that we need to care very closely about mood symptoms as well. Okay, so I promise not to depress you talking about mood symptoms, so here's some good news. So what can we do about these symptoms? If you recognize this in yourself or in someone you know, what can you do about these kinds of symptoms? And the good news is there's lots of tools to choose from. So we have kind of three categories of three toolboxes, if you will: medications, counseling, or what I like to call talk therapy, and also exercise, and I'll talk a little bit about each of these. This is literature that's drawn from the general population and is not specific to AIH yet. So we are really living in an age now where we've had an expansion of antidepressant medications that are available to people. We know that brain chemistry is unique, and brain chemistry for each individual changes over time. But we know that there's a variety of antidepressant medications to choose from now, and we have more now at this part of medical history than we've ever had in the past. So there are different families of these medications. There was the oldest family of medications were called MAOIs, and those are not routinely prescribed any longer for depression, and certainly not for anxiety. The next generation of medications are called tricyclic antidepressant medications, and so nortriptyline, amitriptyline are common medications. In diabetes, these can be used at low levels to treat neuropathic pain, and at higher doses to treat depression and neuropathic pain, and so there's a kind of a 2-for-1 benefit there. And then the next family of medications that came on the market starting in the 1990s were called SSRIs, or selective serotonin reuptake inhibitors. So examples of this are fluoxetine, or the trade name for that is Prozac. Many of you have heard that medication name. And there's a whole spectrum of these medications now that are available. And then the most recent cousin to that family of medications are what's called serotonin and noradrenaline reuptake inhibitors, or SNRIs. And there are several of these medications on the market as well. We also have medications for anxiety, so people do not need to suffer with anxiety symptoms, and people don't need to suffer with depressive symptoms. There are tools for this. There are medications that are taken intermittently on an as-needed basis. There are other medications that are taken daily. And so it's important to have a conversation with your provider about these symptoms. Many providers may not think to ask you about mood symptoms, but it's very important that if you as a patient are experiencing a change in mood symptoms, that you share that with your provider, because it does make a difference both in terms of adherence and potentially in terms of disease course. And so this is important information for your provider to know and for you to share. Another set of tools that are available to treat mood symptoms are counseling, or talk therapy, as I like to refer to as talk therapy, because the active ingredient is talking. We have different brands of working with people, or different therapeutic orientations is the technical term here. The one that has the most research behind it is what's called cognitive behavioral therapy, which is a skills-based approach to better manage depression and anxiety symptoms. And this is very much a here and now. There's no sofas, there's no cigars, there's no Freud involved in any of this. It's all about working on skills. It's some take-home exercises to work on skills in between seeing the counselor or therapist. It can be done in a set number of sessions. That can be a couple of sessions. That can be a few more than that, depending on what your needs are. People typically meet with therapists one-on-one, but group formats are also very effective using this approach. And most importantly, you're in charge as a patient if you're working with a therapist along this. You set the goals. What's important to you? That might be related to AIH, that might be unrelated to AIH, but it has a downstream effect. And so this is a very empowering approach to helping to work on mood symptoms so that they're not getting in your way. We also know that families are part of the chronic disease experience, and sometimes that can be wonderful, and sometimes the strain of chronic illness can have an impact on couples and families. And when that's not going smoothly, please know that couples and family counseling is available. And there are all kinds of dynamics that can be played out. Family members can play an integral role in chronic disease management. That might be things as simple as renewing prescriptions, or dealing with the insurance company, or setting up medical appointments. It can be much more involved than that, depending on the person and what their needs are. But if you find that you're having difficulty in the context of a family or a couple's relationship, counseling is available to work together to improve communication. Patients may be in a position of needing to teach family members, very well-intentioned family members, of how to be helpful to the patient. Care and help is like art. It's in the eye of the beholder. And so the patient gets to choose what's truly helpful. But family members won't know that if we don't share that with them. Likewise, family members may have very different kinds of experiences of the chronic illness than the person who has the chronic illness. And so we want to respect that that's a very different experience for the family member, and have the family member share those feelings as well. All kinds of worries and things can come up. And so this is an important part of the whole picture. Finally, we have been learning more about exercise as it can be helpful, particularly in treating depression. And so there's been increasing call for exercise as medicine that's been identified by the American College of Sports Medicine and other entities. When it comes to depression, we've been learning in studies of studies, meta-analyses that look for trends across studies, that exercise trials tend to be effective in treating clinical depression. Exercise works if you do it. And it has a little bit of a half-life that lasts about 7 days. So a bout of exercise will be helpful in mood for about 7 days. But then if you don't do any more exercise, good feeling is gone. We've been learning that exercise is not only helpful in addressing mood symptoms, but it can also be helpful in preventing the return of mood symptoms. And so we've had many studies now that have helped to document that. That can be aerobic exercise, that can be resistance training. Good exercise, the hallmarks of that is that it needs to be fun, and Dr. Jones will talk much more about that. It also needs to be appropriate to your medical status. And so having a conversation with your providers about what's appropriate for you right now and with your body as it is today is an important conversation to have so that you can have good guidelines about what you should and should not do with regard to your medical status. Okay, so taking a summary here, we know that chronic illnesses like AIH can pose multiple challenges to patients and their families. We know that mood symptoms, whether that's depression or anxiety or disease-related distress, can be part of the illness experience. But an important takeaway here is that it's not a part of the illness experience for everyone. So it's not a guarantee. That's true in diabetes, and that also appears to be true, even more true in AIH. We do know, though, that when those symptoms occur, that they need to be treated and they can be treated. And we have a variety of tools available to serve that role. There's much more, as you can tell, that we need to learn about the patient experience and the family experience of AIH. It's very exciting as a researcher to see the emergence of this literature. It's high time. I would suspect many of you might agree with me in thinking that it's high time to learn about the psychosocial component of this. We have been doing that work in diabetes now for about 30 years, and we've learned a great deal, and there's even more we have to do in diabetes. But whether we have many studies or a few studies to choose from, the most important piece, I think, about the patient experience is that you are the expert about you. So that when you are meeting with your healthcare provider, you now have some medical expertise, thanks to today's program, but you are the expert about your experience, your treatment history, your symptoms, your context. That's very important information for your provider to know. And so I invite you to share all of your experience, your mood symptoms, your context, your struggles, if you're struggling with adherence. Share those with your provider and help your provider to be helpful to you in maximizing your health outcomes. And with that, I will stop for today. Thank you.